you uh, hope you all can hear me. Can you all hear? Yes. Okay. Okay. I'm Dr. Vijayanayaka. I'm a senior lecturer attached to the Kotalala Defense University. And so what we have planned today is to discuss as one patient who is with rectal cancer to understand every aspect of management of rectal cancer. Okay. Because what we thought is it's no point we trying to discuss so many cases if we don't go into in-depth concepts of managing a particular condition. Okay. So our patient is a 32 years old male, and he's a instructor. He was working as an instructor of a gym in Dubai. But when he got these symptoms, he returned to Sri Lanka to get it investigated. That was last year, November. And he was diagnosed with a low rectal cancer on the 17th of November last year. Okay. So shall we discuss what principles are there in planning to assess this patient? What are the things? How will you plan this patient assessment? So we all know that we need to get a detailed sorry, I couldn't. And with us today, we have senior consultant oncologist, Dr. Yasantari Ratna, and we have radiologist, Dr. Eranga Ganewatta. And then in a while, Professor Pramod Chandrasinghe will be joining us. He's a surgeon. And both of us are colorectal surgeons. And so how will you, when you get a patient like that, how will you start planning the management? These principles applies to every patient. It is not only for cancer patients or not only for rectal cancer patient. It applies across the board. First thing, when you suspect some condition, we need to establish that condition is actually present. So we have to confirm our diagnosis. Or if we have more than one differential, then we need to make sure that those differentials are, some of them need to be excluded, some of them need to, or one of them need to be confirmed. So the first principle of planning the investigations is to establish your diagnosis. And once you establish this diagnosis, next principle is to assess the severity of this condition. So how will you do that? And what do you mean by severity? In a benign condition, yes, it is the severity. But in a malignant condition, what we look at is the stage of the disease. Okay. And next set of investigations, we plan to assess this patient as a whole to to ascertain whether this patient is suitable for certain management plan or certain treatments. Because now, for instance, in theory, if you take a low rectal cancer and if it is beyond T2, then these patients need neoadjuvant chemoradiation. That is in theory. But if your patient is 91 years old, would you do that? And I suppose Dr. Ariyaratne will discuss this in detail. And if the patient's general condition is compromised, can we do that? No, because most of these drugs are cardiotoxic, renal toxic, and unless the patient's general condition is suitable, we can't carry out certain things. And if the patient's ejection fraction is 20% or 35%, we can't carry out a major resection. So we have to tailor-make the management. And whether we can employ some other alternatives or whether we have to take the risk and go ahead with the protocols. So that is what we need to assess. And so what are the diagnostic tests that we carry out in the case of a rectal cancer? Any of you? How would you first confirm your diagnosis? How will you first confirm your diagnosis? This is an interactive session, so you have to answer some of these questions. And you do these things. Right? How will you confirm it? Sorry? Yeah, what would you do? Why colonoscopy? This is a rectal cancer. Why colonoscopy? And what is the percentage of synchronous lesions that you would find in general? In general, to be exact, it is 4%. But if you 5% is accepted. Okay, and so we need to carry out a colonoscopy, and then we take biopsies and we confirm our diagnosis. Okay. And next, what would you do? How will you, can you get a rough idea about certain indirect ways? Can we get a rough idea about the tumor burden? Any investigation that we can do? What's it? Carcinoembryonic antigen, tumor markers, right? And however, we know that in more than 25% to 30% of the time, TCEA will be negative. So they are non-secretors. Right? And next, what should you do? We need to stage the disease. And when we get a rectal cancer, how do we do that? A rectum is in the bony pelvis. So what is the best method of assessing the locoregional disease burden? Sorry? MRI. What would you write in this request form? MRI, what? Sorry? These are things you are doing day to day, in your day-to-day practice, aren't you? But what should you write exactly? What type of MRI you want? So you need an pelvic MRI with anorectal protocol. Because when we, and I'm sure Dr. Ranga will take you through this, but it is important to follow, because the protocol that you follow to assess a any other pelvic pathology is different to the protocol what we follow to assess the rectal carcinoma. Okay. So this patient also underwent a pelvic MRI, and we are going to show you them, and we will be taking you through the MRI findings. And then next, so this will give us an idea about the locoregional disease burden or T stage, and the local nodal involvement, and Eranga will discuss what is best to assess certain things. I'm not going into details. And then we need to assess the involvement of the regional lymph nodes, because you know, in all the bowel are drained by 3 levels of lymph nodes, that is D1, D2 and D3. D1 nodes are right next to the bowel wall, and D2 are along the supplying blood vessels, and D3 level is where they are at the origin of these supplying blood vessels, so apical nodes. So that is what we need to assess. And the next is whether there are distal mets. And how do you assess that with a rectal cancer? Sorry? Contrast enhanced CT. Yeah. Okay. Yes. Chest, abdomen and pelvis. So the need of pelvic CT with pelvic MRI we can ask from Dr. Iranga. Okay. And so I'm going to ask Dr. Ganevath to discuss the first MRI of this patient.
Hi, good morning, everyone. So we'll look at the MRI of this patient. Okay. So for any rectal cancer, the primary staging or the local regional staging would be done by MRI. What you need to request is a rectal protocol MRI pelvis. So generally in a rectal protocol MRI, we would concentrate on the tumor itself in the rectum, and we'll have few cuts of the pelvis, entire pelvis, just to see the locoregional lymph nodal metastasis. So in these MRIs, in our practice, we generally use little bit of gel, that is ultrasound gel in the rectum, just to distend it slightly so that the collapse of the rectal wall might not give a false information of the tumor extension. But generally, you don't need to give too much. If you give too much, what will happen is you will expand the rectum. If you give too much of contrast, and it will be, because we need to see where the distance between the mesorectal fascia and the rectal growth. So if you give too much of rectal gel, it will distend the to an extent that it will come very close, and we will get a false positive impression of MRF involvement. So in all MRIs, what we need to is to first you do a overview of the tumor, and then you do all cross-sectional according to the long axis of this tumor. So in other protocols, we don't do it that way. So if you just say MRI pelvis, you might get a different angles of the MRI, and the local staging will be wrong. So you have to write it very specifically saying that should be a rectal protocol, because then the technician will look at the tumor, and then according to the tumor origin, they will align your investigation. So you need to be very specific when you are requesting. So if you look at in this MRI, this is the first view that we will go through, and you will see in the sagittal view, you can see where the tumor is. And then this is the anal verge. Then you see the anorectal junction, and you measure the lower border of where the lower border of the tumor. Depending on where the lower border, you will stage them to lower, mid, and upper. So from 0 to 5 will be lower, 5 to 10 will be mid, and above 10 will be high rectal cancer. So then you have an overall view where the tumor is, and then you have a look at the coronal view just to see whether it's a polypoidal growth, or whether it's a circumferential, or how the tumor has been originated. And then in this view, you can see this a large polypoidal growth with extensive involvement. And then you go to a axial view where you would see a nice overview of the tumor. In this, then you see that it's a semi-circumferential growth of the rectal tumor. So you have polypoidal, circumferential, and semi-circumferential growths when you describe in the gross anatomy of a rectal growth. And when you find that, when you have already saw what is the growth pattern, whether it's a semi-circumferential, polypoidal, or circumferential, then you know it's a lower rectal cancer. And then you have to know the local extension of the tumor. So if you look at, this is the normal rectal wall where the tumor is not involved. So the extension would be from 6 o'clock to maybe about 1 o'clock of the rectal wall. And then you can see this is the nice uninvolved rectal wall. You can see it as a hypo-intense, like dark, because it has fibrous tissue. And then, of course, in this line, you can see there is little bit of haziness, and there is some lines going towards the mesorectal fascia, right? And this is the mesorectal fascia. You can see this light, very tiny, dark outline is the mesorectal fascia. So this is the mesorectal fat. And then you see how the tumor has been extended beyond the serosa into the mesorectal fat. And then, so you can see that the tumor has extended. Then you have to, in our report, we generally say where the most extension into the mesorectal fat. And then you measure the distance from mesorectal fascia to the longest distance from the tumor extension in particularly, right? So in this here, you can see that the tumor has extended from approximately 7 o'clock to 9 o'clock position. You see there is tumor extension into the mesorectal fascia. But yet you see the tumor has not really touched the mesorectal fascia. So this is not really involved. But in these rectal MRIs, if you see a lymph node, which is touching the, here, you can see there's a lymph node in there. But if the lesion is touching or less than 1 millimeter between the rectal fascia, you call it as a MRF involved. Either you see the direct invasion of the tumor into the mesorectal fascia or a pathological lymph nodes, which is touching or less than 1 millimeter from the mesorectal fascia, you get it as the involvement of the mesorectal fascia. And again, you might see there is tumor extension in at 12 o'clock position also, which has almost reached the mesorectal fascia. So there are two areas of mesorectal fascia involvement in this patient, right? So generally, you can avoid contrast, giving contrast to in a diagnostic rectal staging, primary staging, not the secondary one. Follow-up, you can avoid, but sometimes if the lesions are not very conspicuous or you can't identify whether when it's a flat lesion, and if it is in a very bad angulated lesions, you might not see it. So generally, sometimes we tend to give contrast also for the primary staging as well. So once you see the extension, you measure the distance from the serosa to the extension, depending on whether it's less than 5 millimeters, up to 5 millimeters or 15 millimeters, you stage with T. So T1 and T2, we can't differentiate it on MRI. So you have to do a endorectal ultrasound or an endorectal coil to use MRI to see whether it's T1 or T2. But generally, we can see whether it's T1 or T2 or T3, which means it has extended into the adjacent mesorectal fascia. And depending on the distance, you change 1A, 1B, 3A, 3B, 3C, and 3D. So once you do that, of the primary staging of the tumor, you look for the lymph nodes. So first, what we'll have to look is lymph nodes in the mesorectal fat. And if you look there, you have a lymph node here, which is touching the mesorectal fascia. And then there's a lymph node here in the obturator region. So these are all locoregional lymph nodes. Depending on the number of the lymph nodes, you will stage again N1, N2, or N0, depending on the number of local lymph nodes. So once you do that, the next one would be to say whether the MRF involved or not. So if it is MRF involved, you will say MRF plus, or if not, negative. And then the other thing we would look for is the extramural vascular invasion. So in this patient, if you see, this is a vessel which is coming towards the rectal growth and the extension of the tumor. So it has almost goes parallel with the vessel. So you will take it as positive for extramural vascular invasion in this patient. So it's a T3 MRF plus N1 EMVI plus also. So it's a locally advanced rectal cancer, which the surgeon and the oncologist will decide what the next management will be. And then shall I go through the CT as well? Yeah, just. So once you do the primary staging on an MRI, we need to do a evaluation of the whole chest and abdomen just to see whether there's any distant metastasis. So it will be contrast CT, chest and abdomen. Do you know what this is? This is a view of the lung. How do you call it? Sorry, I can't hear. Lung window. So in the lung window, you will see the pulmonary metastasis, but not the mediastinal metastasis. So if you see this, you can generally increase the thickness of this. That will give more easy of identifying in very small lesions. So if you do a thin cut, you might even miss a very tiny lesion. So you need to increase the slice thickness, which will easily allow you to identify the pulmonary metastasis. And then, of course, you need to give contrast. Why do you need to give contrast? What is the advantage? Oh, why do you need to give contrast? What does the contrast do? So it will outline the vessels. So in the mediastinum, sometimes you might not be able to identify lymph nodes within because there are so many things. So you need to outline the vessels and whatever other structures so that you will be able to pick up a mediastinal or hilar lymphadenopathy. That is one thing. But in the abdomen, so how do you protocol this? Just CT, chest and abdomen you will send, we will protocol it. But how do you generally need to protocol it? I mean, how many sequences you need to do? Just one contrast and do the whole thing is enough, or you need to repeat that to see some certain things? Hmm? 5 phases we don't do. Triphasic. Yeah, right. Yeah. Yeah. So what are the triphasic? Yeah. And you have to do a non-contrast is a must, right? Because you need to see the calcifications. Because if you see some lymph nodes in the chest, it could be very well be some primary TB which had when you're young. And if you see calcification, you might not be able to pick it up if you do just straight away give contrast. So generally we do a non-contrast study so that you can really assess. And then, so what do you do next after do the non-contrast? What do you need to do? So in Sri Lanka, we don't have very, CT readily available. So if you're doing a CT, might as well do the whole study just to rule out any other pathologies as well. Because you can't say that you have done a CT and then you miss something in the small bowel or you miss something in the mesentery, right? So we generally give oral and rectal contrast or negative fluid just to distend the small and large bowel, so you won't miss any tiny thing that you might not be able to see without any luminal contrast, right? So generally we give. It depends on your protocol or your preference, whether it's a positive contrast or negative contrast. I generally prefer positive contrast. Lot of people prefer negative contrast also. So negative contrast, you give either water or little bit of mixing mannitol. So you'll get a good distension. If you just give water, with time, it gets absorbed, then you will not see the expected amount of distension of bowel loops. But if you give contrast, it will stay in there and you will be able to see. So in a place where you don't have a primary staging MRI, you would go away with a CT that you will give some idea of how to locally staging of the tumor, right? So you give oral and rectal contrast or negative contrast. Then you go triphasic. That means arterial phase, generally you cover the chest and the liver, right? So no point covering the whole abdomen. What generally we do is chest and liver, because chest, you will see all the vessels in an arterial. That is, when you give contrast, in about 40 seconds, if you do a run, you will see the whole mediastinum, cardiac shadows, and whatever the lesion. If you have a lesion, you need to assess whether it's enhancing, right? So there are something called lung hematoma, where you have calcification and fat. You will not see a enhancement. Then it's a benign condition, but you will falsely diagnose as a pulmonary metastasis. So you need to assess that as well. And then in arterial and venous phase, you will see the good enhancement of the liver, right? So this is a arterial phase. But if you see it on the venous phase, you need where the liver gets maximum enhancement. And generally, how would you see a liver metastasis? What is the appearance? Straightforward rectal cancer. Oh, so it won't enhance. It will stay there as a non-enhancing, and it will pop out only on the portovenous or venous phase. So the rest of the liver will enhance and the lesion will stay as non-enhanced. But you have to be very careful. There can be cysts. Cysts also will appear as a non-enhancing lesion, but then you go back to the non-contrast imaging, you measure the density. That is, in density, you can see if it is fluid containing density in a non-contrast imaging, you would call it as a cyst. Generally, most of the cysts are benign, but there can be cystic metastasis. So if you see anything cystic metastasis and the primary staging is advanced disease, and you are in a dilemma where you can't decide this is a cystic metastasis or a benign cyst, what would you do then? Yeah, MRI liver, dynamic MRI liver, where you do all the phases, and with the diffusion restriction. Diffusion restriction means you have a high cellularity in that lesion. So if you see a diffusion restricting lesion or cyst, lesions are there, so many lesions can be diffusion restricting. But if you see a cyst with diffusion restriction on MRI, you can, most of the time, it can be a cystic metastasis. But it's a rare occurrence for rectal CA though. There are few things which come as cystic metastasis, but the rectal cancers are not a common lesion to have a cystic metastasis in the liver. So you need to do at least 3 phases of the liver just to ascertain what kind of lesion you will encounter. So if it is a hemangioma, you will see a peripheral enhancement in the initially, which will, with time, in the delayed phase, it get filled in. So it will get enhanced in the delayed imaging. So you can easily diagnose a hemangioma over a metastasis. So there are certain things that you do. If you see a liver lesion, go through all the phases and see whether it remains unenhancing throughout, which could be a metastasis. And you will see those lesions, and fairly, any lesion less than 1 centimeter is very difficult to say whether it's a metastasis or thing. But then you do a MRI. If you can't do a MRI, you might end up doing a liver biopsy if you can see it on ultrasound to ascertain whether it's a true liver metastasis or just a benign lesion. So once you look at the liver, then you go to the para-aortic region. That means around the aorta. You can see lymphadenopathy if it is a distant metastasis into the para-aortic lymph nodes. So in the local, you don't need to go through if you have done a MRI, because you just say there's a lesion with some lymph nodes, but you might be able to see more pelvic lymph nodes, which are little higher up, which might you miss on a pelvic rectal protocol MRI. You might not cover the entire pelvis, because it's a 2 different protocols that you need to do if you're covering the entire pelvis. So if you're generally you do a CT anyway if you're ending up doing an MRI for a local staging. So you might have to see some distant pelvic lymph nodes in the MRI and the CT, and then you have to generally look at the bones just to exclude there are no bone metastasis. So if you want to see bone metastasis, what you need to do in a CT? How do you adjust your windows to see whether there's any bone metastasis? Sorry, just came out. So it's a bone window, right? You have to adjust your window to a bone window. So the bones will be highlighted, others will be hidden. Then you can see whether there's any. Sclerotic means a whitish patch, or a lytic lesion will be very lytic. That means it's radiolucent, and you have generally go through all the image bones just to conclude your report saying there are no distant metastasis. That's how you stage a primary staging of a rectal cancer.
So, Eranga, what's the final radiological staging of the tumor?
It's T3, T3C, N1,
EMVI positive,
EMVA, CRME plus.
CRM plus, and M naught.
PSW negative. Yeah.
M
no
naught.
M naught. Yeah.
M naught. So let's ask the surgeon what he did next when the patient came with this report. This is a 32-year-old patient, remember, with a low rectal cancer, locally advanced, no distant metastasis, but no N1, T3, N1. So you have to consider what you are going to tell the patient as well, right? Because the patient comes with this and asks, doctor, now what, right? So straight up, what are you going to tell him? We'll ask Dr. Vasanta Vijayanayaka what he told the patient.
And as I mentioned, we got CA of him, and it was 6.57 on 2nd of December. That is, and the histo turned out to be an adenocarcinoma. There were nothing was mentioned about the differentiation. Because I got this patient after a few months of diagnosis. So the first MRI, we went through that. And next, patient was, shall we discuss this patient? If we happen to get this patient, come across this patient for the first time, now with these reports, how will you proceed from there? What is the most important thing beyond this? We are looking at a patient who is 32 years old, and this patient came with his girlfriend, okay, and very low rectal cancer with certain markings, fairly nodes positive, EMER positive, and so how will you proceed? Right next to the printer, and then fairly low. If it was T1, I'm sorry, if it was T2, now we know this patient has got a T3C. But if it was T2 tube, what are the options that are available?
What are you going to tell the patient? Now he comes with this report. What are you going to tell him next?
Okay.
Other than
Sorry.
raising your eyebrows, what are you going to tell? 3N1 in a 32-year-old, low rectal cancer. What do you tell him? What is the next step? He wants to know, doctor, shall we operate now? Got all the investigations that you asked for.
Every patient wants the moment that they recover, that they find that they have got a cancer, they want it to come out, right? If it's possible. But in this patient, what are the things that you would discuss?
So we will start by breaking the bad news.
Yeah.
Then I will
You know what? But no, this is we are not discussing theory here. What I want to do is to discuss a real case scenario.
So we will discuss regarding the possible outcomes, the prognosis of his cancer and the possible management options that is available.
That are available.
Then
Okay.
I will also discuss regarding the possibility of a sphincter, that possibility of permanent stoma in this patient and young patient, that risk associated with the fertility and high chance for his nervous injury and future problems with his bowel bladder, as well as his fertility issues with erectile dysfunction and such things. Then I will also discuss regarding his our treatment plan and regarding the neoadjuvant options, surgical options, and his.
So how shall we start the management?
So now there are when you go to a management, there are options, and then there are mandatory actions as well. Some things that you can't get away with, right? You can't tell the patient you can either have this or that. There are there are some management pathways you can say you can either go for this or that. But there are some things that you cannot avoid, right? So what are you going to tell the patient first? Now, before you discuss about all the sphincter preserving surgeries and stomas and permanent stomas, APR and all of that, there are some things that you cannot avoid. You have to tell them first to the patient, because otherwise the patient will think it's a basket and he can choose what he wants. But there are some things that you cannot choose. You absolutely have to give for a reason, right? So what are you going to tell him first up now? Are you going to tell him
In
to do
other
this?
words,
Yeah.
what is saying is, what is your first step in the definitive management of this patient?
The next
M-
step.
MDT discussing discussing the patients in a MDT multidisciplinary team to get a management plan.
Okay.
So when you go to that, are you going with an open mind, or like, you know, whatever the oncologist says, I'm going to accept that?
We ourselves should have a plan and
In your plan, what is the next step? As a surgeon, what do you think is the next step?
this a T3 tumor, we probably will benefit from neoadjuvant.
Be specific. Don't just say neoadjuvant.
Neoadjuvant chemo radiotherapy in this case, because it's a T3C with a circumferential resection margin involved. So he will benefit from long course chemo radiotherapy to downstage the tumor. Following that, we will plan for the restaging and go ahead with this sphincter is involved. Is the sphincter involved? No, not involved. So in that case, we can restage the tumor, and then later we can decide on whether to go ahead with the sphincter sparing surgery or a APR.
Ask the
Yeah.
oncologist then.
Yeah.
So
So
we will,
shall we
so
discuss?
shall we?
Yeah. Anyone else has any other?
So now
Anyone else?
anyone has a
any other
different
thought?
opinion on this rather than that? Yeah, so we take all this information now to the MDT and we are going to present it to the oncologist. Now, let's see what the oncologist suggests, right?
So now the ball is in our court. And you see, when you go back to the history of this patient T3 and the N1, then we have to put the patient into a box like groups, group 1, group 2, group 3, or group ABC or group 1, group 2, 3. So this patient will fall into the intermediary group, that is group 2, because the group 1 to T1 to T3, it can go. In 1, it can remain, but there is no sign of circumferential involvement, pericircumferential involvement.
Yeah, there is, but the resection margins are threatened.
Threatened. So anyway,
Yeah.
that means that the patient will not go into the group 1. So the patient goes into the group 2. That means the surgery alone is not good enough. And we have to go for the treatment with a neoadjuvant type of a treatment. To say, if you are planning for your, what do you call the sphincter sparing, then which one we want to do, short course or long course? Long course is good enough for him because he's a life expectancy is high, 32 years old. Then he had been a gym person and he had had no comorbidities which will interfere with the surgery or with the future life. So what happens is that we have to give him the best of the time, and long course radiotherapy is good, especially if there are any adverse events, adverse markers, that's like a histology. If you are thinking about histologically higher grade or family history, genetical precedence, or on the other hand, whether there are any, as you said, circumferential involvement is there. So group 3 will go for long-term, group 2 will go for long-term CRT,
And-
chemoradiotherapy, 45 grays, that will be about.
And can I disturb, sir? So what are the indications for, even though we don't practice it routinely, for short course chemoradiotherapy or radiotherapy. Sorry.
Well, short course, long course is usually gives good results. Side effects are a little more than the short course, but nowadays short course and watch and wait theory is coming back. So we will have to keep that aside at the moment. But short course, usually what we follow is if we don't have that much of sort of bad effects, or sorry, the high risk factors. If the high risk factors are not there, then of course, if we can get hold of the surgeon to do it within the 7 to 10 days, that
Yeah.
is where I had gone through the trials, and the problem is that the surgery
Maximum wait is 14 days.
yes,
Yeah.
7 to 10 days is the ideal.
ID.
So sometimes we used to send them, but we will not be able to do it, and that sort of jeopardizes the whole chances. But on the other hand, long course, you have several weeks, 6 weeks or more. So
And the other thing is those who are very symptomatic, and if you can't control
yes,
those symptoms, they would be benefited with a short course, isn't it?
yeah, short course is going to give quick results.
Yeah.
So quick responses. So
But
bleeding.
the radiation dosage is high, isn't it?
Radiation dose is low. That is
Low?
20. Yeah, it is 5 days. No, 5 days.
No, I mean per
Per
session.
session is, yeah.
Yeah,
Fraction
per
dose
session it is high.
fraction dose is high, total
Yeah.
dose is less.
Yeah, total dose is less,
And
but
the
fractionated.
total time period is also less.
Yeah.
Therefore, the organs at risk are usually spared because the total dose is less, and the long-term results are also, long-term effects of radiation is also less. But on the other hand, all these things are good if we control the disease only. So the disease control, the surgery is the must. So surgery must be pre-planned and set aside, the time set aside, everything is prepared, then only we go for short course radiotherapy. And this type of a patient, I will go for long course radiotherapy because I'm thinking about his life expectancy, the future, and the recurrence rates to be very much low, expecting that total dose is more, time period is more, but with the IMRT, the facilities which are available now, IMRT, we will be able to reduce the organs at risk damages very much to a certain very low level. And it is involved with the chemoradiotherapy, whereas short course is not involved in the chemoradiotherapy. Long course is involved in the chemoradiotherapy that will reduce most of the nodal and other things. And the tumors with chemo, not with radiation, but with chemo, the tumor recidence is centripetal, that it will go back to where it started. So that will allow the surgeon a good leeway within the sphincters.
Yes.
What is the place for total neoadjuvant?
Yeah.
Yeah.
Can you take the microphone?
What is the place for the total neoadjuvant treatment here?
Yeah.
Yeah, followed by long course.
Long
followed
course
by
chemotherapy.
consolidated chemotherapy.
There are two types of total neoadjuvant therapy that we are looking at. One group is induction chemotherapy, and then to go for chemoradiation. And then the other protocol is consolidation chemotherapy, where you start with neoadjuvant chemoradiation and then follow it up with chemotherapy. So these are two groups, and we will be discussing it
Discussing
at
it in-
some
Yeah.
point.
Your-
Yeah.
your question-
Oncologically, these two are at the moment doubtful over the long-term results. I mean, we don't have the significant guidelines to say that this must be taken for this case because of
Yeah.
the real world data is lacking. But on the other hand, if you want, as you said, that the symptoms are more, going for radiotherapy with a consolidation before that is perfectly all right, because you're controlling the disease. The patients are coming to us for symptom relief. Mainly, they are not worried about the disease, they are worried about the symptoms. So we
Yeah,
have
so
to control the symptoms.
so the patient expectations and the expectations of the surgeons, the expectations of the oncologists, everything needs to fall into place to make these decisions. This is what I want to emphasize here, because the when it comes to surgery, we want to do maximum and to achieve R naught resection. Okay, and when it comes to oncologists, they want to do maximum to control the disease, and patient wants to retain the functions as it was, and they want to live a normal life. They don't want side effects. They don't want long-term consequences. So, but at some point, we have to strike a balance. And that is the reason why MDT is very, very important. And then we have to look at in terms of how much as surgeons we are willing to compromise, and how much as oncologists they are willing to compromise, and how much the patient will have to compromise in terms of his or her expectations. So this is where these three groups have to come into terms.
So did you request for long course chemoradiotherapy for this patient?
This patient
Came
This-
after having it.
Yeah,
Right.
this patient came to me after long course
Chemoradiotherapy.
chemoradiation.
Right. So you asked the question, so if the patient came to you fresh, what is your thinking process? At the MDT, like,
For this patient,
are you going to decide on total neoadjuvant upfront, or you first give long course radiotherapy and see whether it's going to work and then go ahead? What would you have done?
if you
If you were the
had the
primary
option
surgeon.
of
You could have gotten away with it if you asked Dr. Vasantha, didn't you think about long course? Huh? What is your thinking process? What will you,
so
shall we ask the surgeon, if he came to you primarily, would you have gone for long course chemoradiotherapy, or would you have primarily decided on total neoadjuvant treatment?
so this is a young patient, and his expectations, as I told you, are different from a patient who has lived their life. And as I told you, I told you one other information. He came with his girlfriend. Okay. So you need to consider all this when you discuss this patient. And so we had a long chat. If it was, but by the time he came to me, he has had long course chemoradiation. But if he come to me first, I would have had a long chat and explained everything, and I would suggest total neoadjuvant therapy with an intention of organ preservation.
That's the key, right? So you don't think it afterwards. Based on results, you don't decide, let's watch and wait. You decide beforehand. If you want to try watch and wait, you have to go for total neoadjuvant.
You start
You start with him.
with that in
That's-
mind.
That's the thinking process, right? It's not like how it comes, we will decide when, after the reassessment, MRI and all that. No, from from the beginning, because said some important things. Young patient, low rectal cancer, right? He's worried about his sexual function and all that. And low, if it was a high rectal cancer, all these things might not be relevant. You know, you don't try organ preservation in mid-rectal or high rectal cancers. You try organ preservation in low rectals, because that's where the benefit versus the risk balances off. Because you should remember that there is a risk, 20% chance of recurrence in watch and wait, right? That's a very high recurrence rate. For you to take that risk, you need to balance it off with that kind of benefits, right? So all of that is important in making that decision upfront, right? So whoever would have decided this should have considered all of that at the outset before you send it, right?
And one other thing that I need to tell you is that this patient's resection margins are threatened. So, and if you are looking at R note resection, and when should we, and what should be our basis on deciding the surgery? Is it the initial MRI findings, or is it the findings at the last MRI that we see following neoadjuvant therapy or failed TNT? What should be our basis on making decisions? Suppose you get this patient, the circumferential resection margins threatened, and then you subsequently, following low course chemoradiation, you get the same patient with reassessed MRI saying the resection margins are not threatened. Which MRI would you consider when you make the decision? Always we base on the initial staging of the disease. And I'm sure Pramod will,
Yeah.
yeah,
We'll catch that up.
yeah, we will
post,
be discussing that. So and one other thing on these MRI findings I want to emphasize here is that Dr. Ganewata said that the margin clearance, what is the importance of a clearance of 2 millimeter, and what is the importance of 1 millimeter and less than 1 millimeter? If your resection margins, and he said if it is less than 1 millimeter, those are threatened margins, isn't it? So the local recurrence rates change drastically. And if it is if you go through the literature, it is for more than 2 millimeters or 2 millimeters, means we are looking at about 4% to 5% local recurrence rates, or even less. But if it is 1 millimeter, still it is acceptable around 6 to 8%. And if it is less than that, it goes up to about 20%. And
we'll discuss
yeah,
those we'll go ahead with the patient progression.
And so how will you, so this patient had a long course chemoradiation, and it concluded on the 1st of February this year. Yeah. So he came to me with this MRI. What was done on the 11th of April. That is 10 weeks after completion of the long course chemoradiation. Yeah.
You put them up.
Yeah.
You have the repeat. You have the repeat.
Yeah.
So we look at the repeat MRI.
Make a screen negative.
Right. Okay. So this is the post chemoradiation MRI. So generally, again, you look at the same sequences, but any follow-up MRI, usually you need to include a DWI and ADC, where you see whether there is diffusion restriction, and I usually include contrast enhanced imaging also, because just to see, you need to be 100% sure there is no residual tumor if you are following up a rectal MRI post chemoradiation. And this is so in this one, that you again see there is, you can't see the lesion that you have seen in the previous MRI. You saw a very large lesion, but what you see here, it's a dark area in the same area which was the involvement of the tumor, but you don't see any tumor signal here. It's very dark. Dark means it's fibrosed. So generally, if you look at it, I would go through a few diffusion, which in this series I can't see, but generally you would do a diffusion restriction imaging as well, just to make sure there is no residual tumor. And then you might even do a contrast imaging also to not make sure there is no enhancing tiny components, to make sure that there is no missing elements of residual tumor. So what you would see is a very dark fibrosed area in relation to the previous tumor area, and you can see the MRF is also has completely cleared with some desmoplastic reaction, residual desmoplastic reaction. You can see the MRF nicely, no attachment at the moment. That means it has regressed, the tumor has regressed, as Ariratna sir said, that the tumor has gone into where it started. So there is no residual tumor at the moment, but there is few residual desmoplastic reaction which has gone up to the vessels also, but there is no residual tumor at all at the moment. So it has completely regressed the tumor with fibrosis. So it is, if you go through it, there's a scale of tumor regression scale also. It will be complete tumor regression response to neoadjuvant chemotherapy. Not chemotherapy. Yeah, chemotherapy. So there are no residual lymph nodes, no tumor signal in the residual rectum, and no involvement of the MRF now. So in node, tumor regression has complete, no residual lymph nodes, and MRF is not threatened at the moment in the latest MRI.
What do you do now? Patient came with MRI only, you haven't done an endoscopy now.
I have not done the endoscopy yet. This is the first encounter I had with this patient. So how will you proceed from here?
Patient comes, what do you do? Restaging colonoscopy.
Do you need a colonoscopy? Sorry? Okay.
What about a digital rectal exam? After that. We always forget about the most important thing, right? Because digital rect, why am I asking this? Yeah, no, now, so you're going to put an endoscope in? So why do you want to put the finger in and
Have a tactile sensitivity.
why? He has seen, you're going to see it from the outside, he has seen from the inside. What is the importance of it? I accept your answer, but you have to know the reason. At your level, you can't just give a right answer and get away if you don't know the reason, right? You want to get a tactile sensation or feel the tumor. Why?
The reason.
To differentiate, it is actually has regressed or it is
So you put the scope and you can see that.
Mucosa is normal.
That is
that is
no.
only we are seeing the mucosal aspects, sir, but
Oh.
this one we can feel through the tumor wall.
But then
so
the MRI has
Your
given you
radiologist
that
says it's not.
information.
There is no tumor. Would you still do that or no?
the mobility and
All that you can do with the distance you can assess with the MRI. It is part of the reassessment. If you are planning to go for organ preservation, the field in the digital rectal exam is one of those, right? So only three: digital rectal exam, sigmoidoscopy or sigmoidoscopy because it's always a low rectal,
Yeah.
and MRI. All three has to confirm, right? Out of this, what is the most sensitive? You don't go for organ preservation without knowing this. That's the important thing, right?
This is
Oh,
there
it's
is
not a
one
side-
out
your
of the
patients
three.
will jump at it. When you say organ preservation, patients will have a party, right? But it's not that simple. Right? You need to have all these three. What is
I-
more sensitive?
flexible sigmoidoscopy and biopsy, we have to
No,
reconfirm.
I told you no biopsies indicated.
No biopsy.
If you do a biopsy, you're going to ruin the entire thing. Because next time he will report that there is a tumor recurrence because of the inflammation. You take a biopsy, it causes inflammation, and he will report it as tumor. Yeah, you will get lymph nodes. Biopsy is not a part of assessment. Digital rectal, MRI, and flexible sigmoidoscopy. Out of that, MRI is the most sensitive.
Most sensitive. Why?
Right?
Because it's a
With
three-dimensional-
the finger, you can feel the texture of it. You can feel the mobility of it. You can feel the distance and everything. But that is on the surface. And with flexible sigmoidoscopy, you can assess it only by visual clues. But what is happening underneath that can only be assessed with the MRI. So I carried out a colonoscopy. That is because
You haven't.
this is the first instance I came across this patient. Because the first colonoscopy report, I was not happy about, to be honest. So then I wanted to exclude the presence of a synchronous lesion. Nothing was mentioned about it. And it was not complete, the first colonoscopy. So I thought I should do one. And this is what I saw. Then I ordered a MRI.
What are your thoughts? Are you happy?
There is a sessile polyp inferior to the tumor, sir. It is
Is it-
centimeter in
Is it a
size.
polyp?
Yes, appearance suggestive of polyp, but I'm not sure.
Yeah.
We will discuss some theory on this later on.
Yeah.
As you see it, are you happy to go for organ preservation? Do you think the surgeon is trying to?
No, endoscopic appearance shows it is not completely responded.
A complete response?
Yes.
Okay.
So I would like to go for a radical resection in this patient as the patient is young and
That is the reason that he wants to avoid the surgery also. What is the radical
high
resection
risk
you are
of
suggesting?
recurrence.
APR.
depending on the level of the tumor, I will.
You see, it's coming right up to the edge.
It is coming right up to the rectal junction. So your pelvic floor, your sphincters, top of the sphincters are all threatened.
Okay, so let's say now we ordered a MRI, right? What did that?
Yeah.
Was that the one that we saw?
No.
You know.
Actually, there was a delay in doing this MRI from the patient's various issues. And I think Eranga, you have this MRI as well.
Another 5 weeks after the second one.
One after that. This one. Yeah. This is another 5 weeks after. 15 weeks following the completion of.
So again, you see that fibrotic band on the right side. See, it's very dark, and you can't see a tumor signaling again in here. And then looks the same, almost the same, with complete regression of the tumor replaced with fibrosis. You can't see a nodule which you have seen on the colonoscopy. It's very subtle on the colonoscopy as well, but I can't see anything concerning of that particular finding.
This is about after the
Colonoscopy.
because the patient had some logistic issues and they delayed.
There is little bit of fibrosis for my liking that it goes towards the MRF at 11 o'clock position, but doesn't look like a tumor, residual tumor. It looks like the desmoplastic reaction which you initially had, and then the post-chemo radiation there is no residual tumor at all that you can see, and there are no lymph nodes as well. So it remains the same as the previous MRI without any tumor signal that we can see on MRI.
If I ask, what is the tumor regression rate?
TRG2, because it's a fibrosis without any tumor, tumor signal. Yeah. So at that point, what are your thoughts? Yes. Ask.
I have a question there. What is the reason for the repeating this MRI, sir? Is this because of that presence of polyp?
No, why? The first MRI has happened on 10th of follow-up. And that has had been reported as, I think tumor regression grade was 2. That is what was reported. And then I had this patient, so I wanted it to be done at 12 weeks of post chemoradiation, because the protocol is every 3 months you have to do the MRIs, because 2 weeks following this response of is very important. Those 2 weeks are very important for us to make the decision. However, it got delayed due to various reasons of the patient side, but that is the rationale of asking for a repeat MRI.
So now 2 subsequent MRIs, there is no tumor. What are you going to do now?
Now, what will you do?
So the,
This has not started with the intention of going for organ preservation. However, now you have got this patient with TRG2, that is tumor regression grade is 2, and it's completely fibrosed, and patient is 100% asymptomatic, and he has no issues at all. So what are your thoughts now?
Now,
So-
what will you tell the patient? Now, patient also knows there is no
So the-
tumor.
in this case, there is a complete radiological response in a repeat MRI. So I will tell the condition to the patient. The option is either adhere to the previous plan, whether to go ahead with the APR, but considering his young age and
No, that you'll have to ask the patient, right? He might want, right? You can't make that decision. Okay, let's say this patient is not very keen on obviously 32-year-old is not very keen on getting APR. So now what are you going to do?
in that case, I need a whether there is a complete pathological response. For that, we have to go for a biopsy.
How can you assess it?
We have to go
You
for
can only assess that if you do the APR.
Only way to assess that is to excise it in whatever the way. I mean, whether you go for sphincter preserving
Yeah, now
surgery
if, let's say even for some reason you get that answer, there's a complete pathological response, then what will you?
then whether we are going for a watch and wait with the
No, still I say
frequent follow-up with the MRI.
I won't agree. What do you want to do with it? Yeah. So you can see the surgeon is pressing because the patient is also pressing for no surgery.
Can you take biopsy?
Huh?
Can you take biopsy?
What is the problem? Eranga won't like it the next time you send. There will be inflammation. Huh? No, now you are still missing the point here. Now, for you to discuss all of this, no, even when you go to the MDT, you should know that. Now, you are talking about organ preservation here. I would say still we are not in a stage to talk about organ preservation. Huh? Huh? Yeah, we have not given him consultation chemotherapy.
yeah.
Right.
So
We have
what
just this is
if
an
you-
incidental finding. Actually, because this patient defaulted treatment. Otherwise, he would have got the APR
The
long time. Right? This is how they recognize organ preservation, right? You know that it was invented in Brazil, not in the UK or the US. The patients come after the chemoradiation, come in time and they get what the protocol says. But there was a cohort of Brazilian patients, they're just like us, right? So they did not come. They turned up years later. They started doing MRIs and then tumors gone. That was the cohort that Anjali Tabagama followed up and suggested that you might be able to do it, right?
Can you give the mic?
Yeah. Those are the best controls.
Yeah. That's the real world evidence against the versus the control settings.
Yeah.
So we always go by the control settings most of the time. But then real world evidence might say something else.
Because nobody will allow you to do a randomized trial when you know that neoadjuvant surgery has the best result. Nobody will pass your protocol if you suggested something like this, right? So these are always, science is on serendipity. You find something suddenly and then you go on with it, right? Lab coli or whatever. There is no randomized trial for open versus lab coli, right? So just like that, no randomized trial for any practice change. Most of the time, practice changing things happen like this, out of serendipity. Suddenly you come across something like Louis passed, right? Then you go on.
Sir, I have a doubt. We are giving TNT for organ preservation or mainly to prevent the systemic recurrence?
We'll talk about that. If you want to go for organ preservation,
Yes,
look at the
sir.
other side of that, right? If you want, you have to give TNT.
Okay.
You can't stop with chemoradiotherapy.
Yes.
And because it has happened incidentally, you can't just stop there. So that's what I said, for you to consider organ preservation, you have not completed treatment, right?
Okay.
First you go ahead with the treatment
And-
and then talk.
Actually, when I saw this MRI, what I did a flexible sigmoidoscopy on this patient to assess whether they are about that so-called polyp or whatever that was there. It has totally gone missing. So nothing was there. It was just the scar. Right? I am not having that. I couldn't get the photograph of it. And so then we discussed this patient at the MDT again, because that was the first encounter that I had, and then we discussed this patient at the MDT. And we decided the best way forward is to so this is what I discussed earlier. So from there onwards, how we would proceed depends on the staging, the original staging, and the location expectations, and the available options. And at the MDT, it was decided we will go for organ preservation. Even though we did not start this as a total neoadjuvant therapy, and but with this response, now he is undergoing consolidation chemotherapy. Okay. Yeah. And I'm sure, yeah. Okay.
So that is a crossover, right? Initially, because he came from somewhere else, there was no intention of giving him TNT. But when he came to us, because we wanted to discuss something like, these are the real life patients that you get, right? You don't always get the fresh patients, okay? So, but if you know the evidence and know how to apply it on patients, then you know how to manage these kind of real life problems, right? The objective of learning is to apply it in real life problems. If you can't solve a problem, there is no use to your encyclopedic knowledge, right? You need to be able to apply it. And the application doesn't come from introduction, method, results like that. You get patients in the middle of the journey, and then how you apply, right? So that's why I said you're going round and round organ preservation without realizing the fact what is TNT. Right? If you give TNT only, you can go for organ preservation. Right?
And briefly, shall we ask Dr. Ariyaratne to mention what chemotherapy options that we can employ as consolidation chemotherapy? Can you give the mic?
See, all these colonic and colorectal malignancies are based on the chemotherapy is based on the 5-fluoro, 5-FU or
5-FU.
5-FU, which is a fluoropyrimidine. So it has to be there a fluoropyrimidine. But then fluoropyrimidines are given after a DPD test, DPYD test. So if the DPYD test is mutated, then of course we are in a gum tree because we will not be able to use that. So we had to use that.
So that is a very important fact. If you could, I don't know whether you could remember, you knew about it, but we could remember from the days that we started doing this. We started as registrars. DPYD test was not available. And at least it was not available for Sri Lankan patients. Still, it is not available freely. It is costly. However, and there was a cohort of patients who died while having their initial chemotherapy. But we didn't know why. And this is a very important issue that we came up subsequently. Yes.
It's if it is if there are alleles which are mutated, then of course there are 2 alleles which will make the patient get 3 times more toxic effects than as expected. On the other hand, others are usually 1 or 2. So if there are no mutations, then of course we can go ahead with DPYD. Based on DPYD, usually we add a platinum onto that. On this case, it is usually oxaliplatin.
Yeah.
So 5-FU can be given in the form of injections, or similar one is the capacitibine, which is again in the form of tablets. So depending on the patient's compliance, we will be able to give the 5-FU and the oxaliplatin. So doublet, 2 chemos are usually given. On the other hand, if the patient, there are certain cases where we are giving irinotecan as well, folfactiri, or if the neuropathy is going to be very high and the things are not so good with the oxaliplatin, then of course, or renal functions are not so good, then we will be giving the irinotecan rather than the platinum. So anyway, we will try to do a doublet. We will not go initially for a triplet, but then we will go for a doublet. If you are worried about the genetical aspects of this, we will go for VEGFR, vascular EGFR, bevacizumab, but then that's extremely costly.
Yeah.
And we will try to do, this is a good response patient and young age. Perhaps I would try the doublet first.
Yeah. That is what is happening currently. Okay. And so you want to go there? Yeah.
Yeah.
Okay. Yeah. Thank you very much, sir.
Thank you very much for coming.
Coming.
We'll break for tea and then.
Yeah.
Assessment.
So now we will break for tea, and then we will come back, and then Pramod will take you through the theory aspect of it, and after that we can discuss, because Pramod and myself, we are here, and then we can discuss about the surgical aspect of this, not only this patient, but about the surgical management of rectal cancer. Okay.
And that I expect to take it forward as a discussion with your experience and what you have seen and what you are learning and how it should be in the ideal world and what are the limitations and then what we do practically. Okay.
මේ මගේ ෆොටෝ එක ගන්න. කවුරු බලන් ඉන්නවද දන්නේ නැහැ. Yeah. She went home and came? She went home and came? Because of the urine. Yeah. That's what has happened. Now what's the plan now? Because the urologist. Yeah. Yeah. Okay. What was the plan of the urologist? We can reverse the stoma. Just what are we going to do with the urostomy? He didn't tell any.
After some time, we have to
Huh? Can we create a conduit? That's the thing. We can do a ureteric transplant and get at least one ureter on this. So, that is the plan. What's leaking? Right. Right. All right. Sure. We'll have to get the urologist to do something about it, no? Right. Can you ask the guys to come in? Ask the people to come in. Hello. 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 Yeah. Oh, I got. Oh. 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 Take it. Take a look. Well, I'm put in you. Okay.
So at the next session, Professor Pramod will take you through the theory aspect of what we do and the basic and the principles of neoadjuvant therapy. Okay.
Thank you. Right. Thank you. So, basically, this is nothing new, right? So neoadjuvant chemoradiotherapies or the total neoadjuvant therapy, these concepts are not new, but we feel that you guys are not really aware of the available, in the sense, the practice guidelines plus the reasoning behind it, right? So at your level, you cannot just say answers and then, reason it out as saying we were taught about this and the sets this way, or Dr. Ganevatta said that you need 1 millimeter in MRI. These are not the answers that you can give at postgraduate level, okay? At postgraduate level, you need to give evidence. In 2025, you have to talk with evidence, right? So when you're giving answers, you will have to give a proper reference, right? Don't just give right answers and look blank when they ask why you're asking. Scientific reasoning is not accepted in medicine anymore, right? You can't give a reason saying, because the cells are proliferating, so we are giving chemotherapy. And if we want a basic science reasoning out, we'll ask that particularly about the physiology or the pathophysiology. But when you're asked, why do you want to go for total neoadjuvant or question like that, you have to answer that with evidence, right? So why I basically title this as Medusa is, the Greek mythological character, Medusa, right? So Medusa she's supposed to be a very pretty goddess who was cursed by Hera, but she has a lot of snakes coming out through her head. And although she's very pretty, if you don't play nice with her, right, she's going to destroy you, right? So neoadjuvant is also like that. Nowadays, you have so many options, just like the Medusa's head. And if you don't select the right one, you're going to end up in trouble, right? So this bit I will just skip for you to know that why we are discussing this topic is because rectal cancers are rising in Sri Lanka. It's currently the 3rd commonest cancer in both sexes. So you can't have an excuse not to know about rectal cancer, colorectal cancer, right? And soon in the next edition, it will rise up to be the 2nd commonest cancer, next to breast in females and probably lung or prostate in the males. We don't still have that data, but it will rise up to be the 2nd commonest cancer. So everybody has to know. It's not just rising, it's rising in the young population. This data is not yet published, but we have done a 12-year analysis of the National Cancer Registry data on 29,000 patients throughout from 2010 to 2021, because we chose to ignore data before that because we know that the quality of the data was not very good before 2010. 40 to 59 years has the highest annual percentage change in the incidence, right? So every year there's a rise in over 10% in the incidence of cancer in this age group, and that's the most economically active age group. That is why you keep getting more and more young patients nowadays, right? So steadily increasing, and now both male and female percentages are almost equal, right? So if you talk about breast cancer, it doesn't apply to the males. Talk about prostate cancer, it doesn't apply to the females. But colorectal cancer, 50-50, both males and females, 3rd commonest cancer, right? And remember, we were just discussing about 85% of our cancers are on the left side. So you will come across more and more rectal cancers than in other countries. In the US, you get about 40% in the right colon and 60% on the left. But in Sri Lanka, not just our data, but data from other units also suggests that more than 85% are on the left side and more than 75% are in this rectum and the rectosigmoid region. So you will have to deal with neoadjuvant chemoradiotherapy very frequently, all right? Now, it's very nice to know about the history of this disease because colorectal cancer, the evolution of colorectal cancer is one of those diseases where you can show a nice story of evidence-based medicine, right? It started with a disease with 100% mortality, okay? And 150 years ago, people used to die because we did not know how to take out the rectum, right? Surgeons didn't know how to remove the rectum. And there was no proper anesthesia. And the goal was to send the patient home. We didn't talk about recurrences. To remove a rectum and send the patient home was success. Nowadays, we have come a circle right around not to operate on the rectum, not because we don't know how to operate, but because we don't have to. We know why not to, right? So it has come from so many stages in the 19th century, 18th century, 19th century, and into the 20th century, where the cylindrical, as far as I see, there are 4 landmarks in colorectal cancer treatment evolution. Number 1 is Miles, suggesting cylindrical excision. Before that, we didn't know that you had to remove the rectum in a cylindrical manner, removing all its lymph nodes. So the recurrence rates were around 80%, right? But he suggested this for any tumor in the rectum, APR, cylindrical excision, right? Extra levator, and that's got the best chance of cure. Then became the era of neoadjuvant chemoradiation. That changed the recurrence rates significantly. Then came the Bill Hill's TME surgical technique, right? Again, that reduced the recurrence rates from 22 to less than 10%. And the 4th most important landmark is organ preservation, which was recently implemented. If you're a practicing surgeon, you should know a little bit about these trials that shows you the evolution of rectal cancer management. The Swedish colorectal trial, where they first tried out radiotherapy. Remember, at this stage, there was no TME. Bill Hill has not suggested TME at this stage. They just gave radiotherapy, and to 2 cohorts, 1 cohort received radiotherapy, the other didn't. And it said that neoadjuvant chemoradiotherapy improves local recurrence rates, right? So that's the first time they realized that neoadjuvant therapy actually works. And then surgery versus radiotherapy in the Dutch TME trial, that was in the TME stage. So after this, they recognized this concept called total mesorectal excision, and then they applied it into that same study and did TME plus radiotherapy further improves local recurrence rates. Right? The German colorectal trial, where they checked whether you need to give it neoadjuvantly or adjuvantly, which decides that neoadjuvant is better with the outcome. EORTC trial, again, neoadjuvant long course versus long course radiotherapy only, which proved that adding chemotherapy has a benefit, right? This is not consolidation chemotherapy, this is induction chemotherapy, which you give in long course chemoradiotherapy, right? And then the Polish and the TROG trials, which tried out long course versus short course, which said there is no difference. But for all practical reasons, nowadays, short course has had a slow death, right? People don't practice short course anymore for several reasons. Right. So when you talk about neoadjuvant chemoradiotherapy, one important step is decision making, all right? Which patient and which modality, because you now have so many options available. Reevaluation is a very important concept that has emerged recently, right? Those days we used to give neoadjuvant chemoradiotherapy and we know that he's going to have surgery. But reevaluation has come into the picture with organ preservation and so many other modifications in the surgical technique. Managing different response levels from complete clinical response to partial response into no response, right? How do you decide in those situations? Good old days, we didn't worry about any of these. We send the patient for chemoradiotherapy, they come back, in 6 weeks, you operate. That's the protocol, right? Doesn't matter whether it has worked or not. It was not part of the management plan, right? And then the complications, a little bit about the complications. So first question is who? Which patients would benefit from neoadjuvant therapy? The best analogy I can give you is this movie from the 1960s, The Good, Bad, and the Ugly. Your rectal cancers can be staged into being good, or the bad, and the ugly ones. The good ones are the T1 or 2, right? With no N. And the bad ones would be the T3s with the Ns, and the ugly ones would be the T4s, right? The NCCN guidelines, these are the latest NCCN guidelines that recommend there are 2 potential treatment courses recommended, either total neoadjuvant therapy followed by anterior resection, or both neoadjuvant and adjuvant therapy for T3 with N1 to 2 with a clear CRA, right? They still advocate neoadjuvant and adjuvant therapy, both with surgery or total neoadjuvant therapy. for the ugly ones, only total neoadjuvant therapy, right? That is a T, if you come across a T4 tumor, now what they say is no discussion, you go for total neoadjuvant and then reassess and see. So the bad ones, there are two, either TNT followed by surgery or neoadjuvant, surgery and adjuvant. The one which we used to do all along. But those are the patients with T3 tumors, T3N1 or T2N1, whatever the bad ones. Ugly ones, only TNT. This is the latest NCCN guidelines from 2025. Okay, so it is in the guidelines now, total neoadjuvant therapy. If you look at the, now NCCN is the American version of guidelines, right? If you go to the European ones, they are still a little bit conservative on using radiotherapy. The Americans are upfront in radiotherapy. They believe all rectal cancers need radiotherapy. But if you look at the European guidelines, they divide your cancers between upper third of the rectum and middle and lower third, two groups, right? Because upper and middle rectal cancers don't behave as badly as low rectal cancers. They behave differently, right? So for those cancers, even up to T2, N1, they don't recommend radiotherapy, right? They are going with chemotherapy alone. As long as the margins are not positive, they do not recommend radiotherapy. Even for the low cancers, T2N1, they still don't recommend radiotherapy. It's only chemotherapy, right? But only for the high risk. So they basically categorize these patients on a risk stratifications, low risk and high risk. Upper rectum, middle rectum versus the lower rectum, right? But the American guidelines are just flat out blanket theory. They don't go into this much of detail, right? Only this last bit will receive neoadjuvant chemoradiotherapy, right? Those are the high risk category. We will look into what the high risk means later on. So, which brings us to the question of risk stratification. This concept of selective approach for upper rectal cancer. See, so this is the evidence why you don't give upper rectal cancers radiotherapy, right? There is evidence to say that total mesorectal excision alone has same results compared to total mesorectal excision with neoadjuvant chemoradiotherapy in upper rectal cancers, right? So when you're managing, because I mean, if you are asked to describe it pathophysiologically, you have a much thicker mesorectal fascia and a mesorectum, right? The fat content is much thicker in the upper rectum. So the chances of the tumor reaching the fascia or the end of it is much less. And even if you damage the fascia, the chances of tumor spillage is much less, because you know that the mesorectum just tapers out when it comes to the lower rectum. And in the lower part of the rectum, it's very thin. So the chances of you spilling tumor is much more, right? So upper rectal cancers, in our unit, we basically don't send them for neoadjuvant chemoradiotherapy, right? But you might decide that on the MDT based on whether they are nasty tumors or not, right? If they are T4, if they are CMR, is the circumferential resection margins are positive, of course, you will have to go for that. So most upper rectal tumors, that's why I say most upper rectal tumors can be managed with partial mesorectal excision without the systemic use of preoperative chemoradiation, right? You don't even need to do a TME. You can take 5 centimeters of the mesorectum and get away with it when it's in the upper rectum, right? So risk stratification is very important. The Occam study also gives you the evidence, suggests that the patients with localized rectal cancer who are classified as low risk based on MRI characterization can forego neoadjuvant chemoradiotherapy, even in the lower rectum, right? So some British institutions, they do not give neoadjuvant chemoradiotherapy if the MRI says that the resection margins are clear. They are categorized as low risk, right? T2 tumors in the lower rectum. Some of them, they do not give neoadjuvant chemoradiotherapy. So they are very, very conservative in radiotherapy, preoperative radiotherapy, right? Because you have evidence, right? You can risk adapt even in the lower rectum, right? So these are the indications if you want to go for neoadjuvant chemoradiotherapy according to the European guidelines. A tumor deposits or suspicious lymph nodes less than 1 millimeter away from the mesorectal margin, or T3 in the distal third of the rectum. T3 cancers in the distal third, or you have tumor deposits, suspicious lymph nodes less than 1 millimeter away from the mesorectal fascia. Those are the ones which will require neoadjuvant chemoradiotherapy. Right? So you have to be selective. Every rectal cancer does not require chemoradiotherapy because there are side effects of chemoradiation. Right? So which brings us now, we are talking about upper rectum, middle rectum, and lower rectum. The concept of the site. Is it important to know whether the rectal cancer is situated in the upper rectum or the middle or the lower rectum? It is important because you need to risk stratify. How are you going to do this? You'll be surprised to know that even until 2020, people did not know exactly the anatomical definition of the rectum, right? You might find so many MRI reports saying it's in the upper rectum, it's this many centimeters from the rectal margin, but I don't think most of the people who report it are aware of actual landmarks of the anatomical rectum, right? Where does the rectum start? How do you recognize the rectum, right? The data only came in 2020 from Royal Marsden, from Gina Brown's unit, where they describe this concept called the sigmoid takeoff, right? It happens at the S3 level, which we learn in anatomy, but how to recognize that in imaging is the problem, right? So you see the mesosigmoid starting from S3 level, and that is where the rectum begins, right? So the sigmoid takeoff is an important landmark that your radiologist has to be confident in recognizing. That is why you need to have a radiologist of your own, or a radiologist who is constantly communicating with you if you're managing rectal cancer, right? You can't do it with a person who sees a rectal MRI once a year, right? Because now all the subjects are subspecializing. So the radiologist who reports a rectal MRI also needs to know a lot of information, evidence about how to stage these cancers, right? Let alone stage. This is about locating it in the rectum, because you'll be surprised. So the same people then ran a study to see how many they have categorized wrongly before they found out this landmark. To see about 54.7% of the cancers which they treated as rectal were actually rectosigmoid, right? So they would have been managed as rectosigmoid without neoadjuvant therapy if they really knew the landmarks of the rectum. This is 2023, right? So all this time that you've been talking about rectum in the CT and MRI and so on are not based on proper evidence, okay? Right. Now, if your radiologist is not conversant about these landmarks, you can do that during your endoscopic evaluation. What we generally use are the rectal folds, right? So you can see the rectal folds nicely when you do a colonoscopy. It's a very good practice to note down in your report with the relationship of your tumor to the rectal folds. You can see a nice low rectal fold, the middle rectal fold, and the upper rectal fold, right? The middle rectal fold usually demarcates where the peritoneal reflection is, and it is very constant landmark. Sometimes you might not find a low rectal fold in the rectums. Sometimes you might not see an upper rectal fold, but the middle rectal fold is always there when you do a colonoscopy. So it's very important if you mark that in your colonoscopy reports. So the next surgeon will have an idea. If the patient goes to another surgeon, they will not need to do another endoscopy, right? Don't just write down as there's a tumor in the rectum, right? In relation to the rectal folds is very important. Anything below this would be low rectal. Anything between the middle and the low would be a mid rectal. And anything above that will be upper rectal. Anything above the upper rectal fold will be rectosigmoid, right? Simple as that. So when you go to the MDT, you also know where the tumor actually stands. Because I have seen so many where the tumor is located at the upper rectal fold above that, being reported in the MRI as middle rectal or low rectal or sometimes. Because what happens is, because of the weight of the tumor, the rectum basically intersuscepts into itself and the tumor falls down, right? So you need to actually put the patient head down and see what the actual location is. So for you to argue that, otherwise you, based on the MRI report alone, you will send the patient for neoadjuvant chemoradiation when they say it's in the low rectum, right? So it's important for you to know where the tumor is when you do a colonoscopy. So two more important studies that I want you to be aware of, both are from Gina Brown's unit in Royal Marsden. The MRI staging of the rectal tumors, right? This is why Dr. Ganevath said that you need 1 millimeter margin. It's not his finding, or it's not a God-given knowledge, because the Mercury study told us that having a 1 millimeter margin is as equal as having R0 resection in your pathological specimen. What they did was they compared the cross sections of the MRIs with the surgical specimen cross sections, right? When you send the specimen, the pathologist cuts them across in large sections and they have large slides. So in those slides, they compared it with the MRI and found out that the MRI prediction of the tumor stage is as accurate or more accurate than doing a pathological cross section, right? So 1 millimeter in MRI is equal to a pathological report of R0, right? So because of the Mercury study, that is why he was talking about 1 millimeter. As a postgraduate student, you should know this evidence. You can't just go there and say that you learned this in the sets, right? This was not found by any of us. This was by the Mercury study, right? It's very nice when, as a scientist, when you talk with evidence, okay? Don't just go out there and give your opinions or knowledge bits that you have found from somewhere, because it doesn't carry any credibility, right? We practice what you call clinical governance, right? You go to MDT and say, no, the MRI says it's more than 1 millimeter, so I'm safe. You can't just say that. Then somebody might ask you, how do you say that? Based on the Mercury trial, right? There is evidence to say that. Only evidence can support. It doesn't matter whether you're the most senior surgeon or not, whether you're a GI surgeon or not, whether you're a colorectal surgeon or not, right? It's the evidence that gives you. If you want to prove it wrong, you do your study and prove it wrong, okay? The second is EMVI. You remember Dr. Ganevath was talking about EMVI. So the same authors, they suggested that EMVI might be even more important than having positive lymph nodes. Their concept is that positive lymph nodes are like your front line in a battalion, right? Of course, they have taken the tumor cells up front on the chest, but that is a good sign that your front line is functioning, right? The tumor has not escaped the front line. EMVI means they have found a pathway evading the lymph nodes, right? So actually, Gina Brown says finding positive lymph nodes might be a good sign rather than finding negative lymph nodes, because your front line is active. You know that your soldiers have blood because they have actually done some work. EMVI is where the tumor finds direct access into the veins and get into the bloodstream without going through the lymph nodes. So that people started looking at it only very late, and that is a better prognostication marker rather than N1. EMVI positivity is an indicator for neoadjuvant treatment, as well as gives you an idea that the tumor is advanced, even if N is not. Okay? So remember that. These are the two studies. So now you have the previous standard of tumor deposits or lymph nodes less than 1 millimeter away, distal third T3 cancers. Now, additionally, EMVI positivity comes into the picture when you're risk stratifying these patients, right? So any of these, put the patient into high risk category, and you have to send them for neoadjuvant treatment. So now the question is what? Which neoadjuvant therapy are you going to give? As I told you, there are two options: long course chemoradiotherapy followed by adjuvant therapy, or total neoadjuvant therapy. What's with total neoadjuvant treatment? It improves survival compared with current standard of care, right? There is no argument about it. It improves survival. TNT improves recurrence rates, both local and distal. That's important, both local and distal. All this time, neoadjuvant therapy was aimed at reducing local recurrence, right? But now we are saying neoadjuvant therapy also improves your distal recurrences, right? The chances of you getting a lung or a liver met 1 year down the line is also less if you get total neoadjuvant treatment. That is quite logical, isn't it? You're giving the patient consolidated chemotherapy. See, this concept that, when you see a tumor in the liver or lung or a lymph node, you have already recognized it, right? You can do something about it. What kills the patient are those cells that are hiding from. Single cells which have deposited in the lung or the liver or the brain or the bone. Those are the ones which are going to come up and kill you because you can't see them. Now, when you attack the patient upfront with total neoadjuvant consolidated chemotherapy, you're attacking those guys, the ones that you can't see, right? Even a liver met, if you know that it's in segment 8, you can take out the segment. But if you don't know that there are single cells lying all over the body, those are going to come up. By the time you do surgery, wounds have healed, and the patient goes for adjuvant therapy, those have started to grow. So that's the importance of giving consolidated chemotherapy upfront. That's why, quite incidentally, they found that distant recurrences are also less. Okay. TNT increases the number of patients suitable for organ preservation. It's not that if you give TNT, you can preserve the organ. It increases the number of patients who are suitable for organ preservation. If you want to consider organ preservation, you have to give TNT, right? So 3 benefits of total neoadjuvant treatment, all right? That is why we are saying it's good. So if you're talking about TNT, you have to know about 2 studies, right? The Rapido trial, sorry, three studies actually. The first one was Rapido. This is the study that brought out this topic during the COVID time, right? So what they did was they gave short course radiotherapy followed by 18 weeks of chemotherapy and then sent the patient for surgery, right? That was the Rapido. Rapido was short course. As I said, short course was dying. They tried to basically resurrect short course radiotherapy with the Rapido, right? But actually, it's not the short course which saved the patients. It's this 18 weeks of neoadjuvant consolidated chemotherapy, right? Because that is FOLFOX. It's not just 5-FU, right? It's FOLFOX, combined chemotherapy. And with that, then they did another study called the Prodigy 23, which had consolidated chemotherapy first, followed by long course chemoradiotherapy, and going for the surgery, followed by adjuvant therapy as we do right now, right? So here they first gave radiotherapy and gave chemotherapy. Here they gave chemotherapy and then they went into radiotherapy, right? Both these studies were done during the same time, and that's when the idea of total neoadjuvant therapy came into light. Okay. If you see the 2 studies, you can see here the local recurrence rates in Rapido is actually more in the total neoadjuvant therapy group compared to the standard conventional group, right? 8.7 versus 5.4. It's a significant rise. This was highly criticized for this, right? Why do you have in your experimental arm, you have more local recurrences, right? 3-year relapses were the same, almost same, right? And but the Prodigy, in the Prodigy trial, you can see the local relapses were significantly low, 4.8 versus 7%, right? And 3-year metastatic free survival was also comparable, right? But this was the main difference. Why? Because these guys went for short course with chemotherapy. These guys went for chemotherapy with long course, right? So chemotherapy was common for both, but short course versus long course. So Rapido was heavily criticized. Rapido trial came out, but I like that trial because that is the trial which brought out the discussion about total neoadjuvant therapy and so on, right? After that, there were so many other trials coming up. But Rapido is heavily criticized and people are condemning it because it used short course radiotherapy mainly, right? Because short course is anyway as considered as dead, right? So we don't talk about short course anymore in the main line of treatment. There's this other study that would be nice for you to know. They did a study called Prospect, where they give chemotherapy only versus chemoradiotherapy. And they suggested that both groups were doing very well. So the actual effect is not from the radiotherapy, but it's the chemotherapy, right? But they give combined chemotherapy, FOLFOX, versus neoadjuvant chemoradiation that we give traditionally. So if you give combined chemotherapy upfront, even without radiotherapy, they will be doing as well as the long course chemoradiotherapy, right? So you can be, they suggested that we take away radiotherapy out from the treatment protocol. That is also being criticized because the study design was not very good, right? Because they randomly chose some patients which had poor response and gave them radiotherapy. So there was a crossing between the two arms. For that reason, it is not very popular. But still, the Americans like to believe it. Without giving radiotherapy, you can do away with combined chemotherapy, right? You can see almost similar, both groups. This is another drug that you need to remember as a surgeon, dostarlimab, right? A new drug, immune therapy, which is only active in those people with mismatch repair gene positivity. That is a small number, right? For now, MMR positive tumors, small study done on 12 tumors, but the response rate is 100%. You can't find the tumor once you give this, right? So dostarlimab, there's 2 doses of dostarlimab and the tumor is gone, right? Total pathological response in all patients. You don't find studies like that, right? It's going to be a magic drug in locally advanced tumors with MMR positivity, right? That's a good thing because these drugs are not very sensitive to the available chemotherapy also. But if you give it neoadjuvantly, dostarlimab, 2 doses and tumor is gone, right? So remember that because it might take away your jobs, right? Remember, right? So where to? Because we have so many options now, because we are talking about so many outcomes, you can't just stick into one protocol. You might find patients with poor response. You might find patients with near complete response. You might find patients with complete response who have already agreed to go for surgery. You might have patients with complete response who wants to watch and wait. You might find patients who get local regrowth when you watch and wait, right? You need to be aware of management plans for all of these patients now. You may get patients where you're not sure whether they have complete pathological response, as you said, complete clinical response. What to do with those patients? Are we offering them watch and wait? Are we offering them surgery, right? Patient might say, I have responded, doctor. Why do you want to take my rectum off, right? Just like you questioned about that small polyp in that colonoscopy picture. So what do you do with those? Restaging, right? As I said, restaging is a very important concept which has come now because of this organ preservation principle, right? Those days we didn't restage. We did an MRI initially, send the patient for chemoradiotherapy, then you do surgery, right? And no point in restaging because nothing to do. You're not going to change your management plan. But now we are doing that, right? DRE, sigmoidoscopy, and imaging, the principal components of restaging, right? All these 3 has to be done. MRI is the standard imaging done between 6 to 10 weeks after completing the long course or TNT. In the era of TNT, restaging plays a larger role because if you don't restage, you don't know whether they have responded or not, okay? Now, this is a typical complete clinical response. You get a blanching tumor like that, right? You can see a little bit of prominent vessels, no mucosal abnormality. You do a DRE, you don't feel nodularity. You do MRI, T2 weighted, high resolution, there is only scar tissue, no lymph nodes, no tumors, right? So only if you have this, you can straight away tell the patient that, okay, let's do, there is an option of watch and wait. But when you're telling that, you have to tell them all the details, not just if you offer them, okay, we can do away without surgery, he's going to jump and take this up. You have to tell him the risks of that as well. Okay, we'll see what the risks are. So if you want to talk about organ preservation, you need to know about the OPERA trial. The OPERA trial, now that we know about total neoadjuvant, the OPERA trials tried FOLFOX for 16 to 18 weeks versus followed by radiotherapy versus radiotherapy followed by chemotherapy. Now, in that patient we got, he already had chemoradiotherapy upfront, then we followed with chemotherapy. So if you get a fresh patient, what should you tell them? Go and have chemotherapy and then give radiotherapy, or go and have radiotherapy and then we'll give chemotherapy. Both sounds equal, but are they? Right? So they did the OPERA trial, and the induction chemotherapy group had a 40% regrowth versus chemoradiation followed by consolidation chemo had 27%. The recommendation for watch and wait was almost similar, right? So out of these groups, after they had the radiotherapy and chemotherapy, 105 patients went into watch and wait, but there was a 40% regrowth. In the patients who had chemoradiation first, followed by chemotherapy, 120 patients went into watch and wait. Out of that, 27 patients had regrowth, right? 30% regrowth rate versus 27% versus 40% regrowth rate. So obviously, chemoradiation followed by consolidation chemotherapy would be a better option, right? So when you're talking about, as I said, when you discuss organ preservation, right? See, even in the OPERA trial, the best results group had 27% regrowth. Okay, that is when you watch and wait, there is a 27% chance that you can have a regrowth. Remember that, right? So this is not all hunky-dory, you can preserve your rectum now, you can go home and have a nice time. No, you need to tell the patient that there's a 20 to 30% recurrence rate. Are you willing to take that risk? Right? Salvage surgery, right? What you say salvage is when you get a regrowth, you go and do surgery, right? It has good outcomes, but the distant metastasis risk in those patients was high, right? You watch and wait, he gets a tumor, you go and do an anterior resection, right? Good, just like you did it, but there are distant metastasis risk. Oops. Distant metastasis risk is significantly higher when you have a local regrowth. That is why you had to choose the correct patient, right? It's not the local recurrence, it's the distant recurrence. You're more likely to get a liver met, you're more likely to get a lung met if you get a regrowth. Okay, so that is important. You have to tell that to the patient. Patient will ask, doctor, what will happen if I get the tumor again? We can operate, but remember, your chances of getting a liver met is more, and that's going to kill you, right? Metastasis is going to kill you. It's not the local regrowth, but the mets that are going to kill you. So you have to tell all that to your patient when you're offering organ preservation. Organ preservation is not something that you can just dish out for everybody. Patient has to understand these risks and benefits, right? So organ preservation is only beneficial when it's in the distal rectum, and the risk of local recurrence is balanced off with morbidity and mortality, right? Not just local recurrence, distant recurrence as well, right? So for a 32-year-old young man who is going to get married, causing impotence and giving a permanent stoma versus taking a risk of 20 to 30% recurrence, you have to let him decide. It's not for you to decide. There may be a patient who says, no, doctor, I'll go for the permanent stoma because I want to live cancer-free and I want to have peace of mind, right? Good, right? So you can't just say, all right, your tumor has responded completely. You go home and come back in 3 months because you're given organ. Organ preservation is not for you to decide. right? You have to tell the patient all these details and let them decide whether they want to take that risk or not. Remember, 30% is, if you send home 3 patients, 1 is going to get recurrence. And that patient is going to get a liver met or a lung met as well. Higher risk, right? So remember that. This is a very good study that they have done, right? This from the same group which actually advocated watch and wait, the Rodrigo Perez and his group. They looked at the tumors that they watched and wait, right? So the distant metastasis-free survival for the patients with local recurrence and TME at reassessment, right? So the patients that went ahead and did the surgery versus patients who they watched and wait and got a recurrence, right? You can see the survival or the distant metastasis risk is much higher in that group, right? These are the patients who had radiotherapy and watched and wait and then had the surgery, right? Versus those who went for primary surgery. Their distant metastasis risk is lower compared to the red and the yellow ones, okay? Right, so you asked, now you can see this one. This is again a T3 tumor in a 53-year-old female. We gave we gave neoadjuvant chemoradiotherapy. Similar picture. There is a small polyp there. You asked, can we do a polypectomy, right? You can, but then the problem is reassessment. So what we did in this patient was, we didn't want to go for surgery because this patient had so many other problems. He had a pituitary tumor earlier, received radiotherapy. She was obese, right? Like her BMI was over 40 and diabetic, and she was having Sheehan's syndrome on steroids, oral, and so many other problems. She wouldn't have survived the anterior resection very well. But now this is not a complete clinical response, as you suggested, right? We don't see that nice blanching scar. There is a small polyp. And this again was in the era where we did not practice total neoadjuvant treatment. We just gave her long course chemoradiotherapy and she came. MRI says no tumor. Finger also, you can't feel anything, but when you put the colonoscope, there is a small polyp. What we did was we excised the scar, right? You said we can assess pathological response. You can't do it with biopsy. If you're doing it, you need to do a full thickness excision of the scar, right? So we put a transanal port and did a full thickness scar excision and sutured it back together, right? Send the scar for evaluation, and scar came as complete pathological response. So now we've been following up this patient. 4 years down the line, she's still tumor-free. But remember, that patient is very obedient. She can afford to get MRIs every 3 months for the first 2 years, then every 6 months. She's rich enough for that. She comes for endoscopies every 3 months, right? These are the patients you can offer organ preservation, not your average patient who will go home and tell the entire village, this thing was cleared off from a miracle and now I'm going to live happily, right? So when you're choosing a patient, you need to choose those also, because your hospital is never going to give a 3-monthly MRI for a patient, right? An average government hospital will not approve a MRI scan 3 monthly for one single patient, right? You know the practical problems with it, right? So they should be able to at least afford the MRI scan for the first 2 years at least. I generally do 3 months. Recommendation is 4 monthly MRIs for the 2 years, right? Because we are just new in the game, I generally do about 3 monthly, but only those who can afford can get it done. Because if you send the form in a government hospital, anyway, the date you get will be in about another 6 months' time, unless he has a cancer, right? So these are practical problems. You can't just offer organ preservation. So we did this scar excision long time ago, 2021, I guess. Scar excision data is now available. This is from 2025, July, right? Just this month. They studied people who had local excision for near complete response, right? 79 had salvage surgery after regrowth versus those who had the local excision. 5-year was lower, the 5-year distant metastasis-free survival was lower in the patients with surgery at regrowth, right? So the patients who had surgery at regrowth, patients with rectal cancer undergoing local excision for near complete resolution after neoadjuvant therapy have a significantly lower rate of distant metastasis compared to patients undergoing salvage surgery after watch and wait approach, right? So if you do a scar excision or local excision, they have a lower risk of getting distant metastasis compared to those who get a regrowth and then do a surgery, right? For near complete response, you can either take out the rectum or you can excise the local scar, right? So for those who, so in those who they watched and wait, higher number of patients had a regrowth. Then they did AR compared to upfront doing something like this when you have a near complete resolution, doing a scar excision and looking under the microscope. Obviously, those who had partial response would have gone for AR and they would have survived, right? So the patients who did not have a local excision and stayed until they got a regrowth, that is also a way of looking at response. No, you leave that patient for some time and they get a tumor. So that is not a complete response. Or else you can excise the scar. But remember, scar excision is not a simple thing. It's very complicated because you can end up in getting presacral abscesses and so many other complications if you don't do it properly, right? You can't just pull down the rectum and close the defects in the rectum under tension. It has to be done very meticulously, and you have to choose the correct patient, correct site, the correct modality, right? All patients, you can't use transanal approach, maybe too high, maybe too low, right? So there are other problems. So these are highly specialized things, but just remember, you need to know the evidence if you're trying to suggest this, okay? So, sorry. Again, remember, once you send a patient for chemoradiotherapy and restage, you can have poor response, near complete response, right? In the complete response, you can send some patients for watch and wait. You can send some patients for surgery because they have already decided. You can get local regrowths in watch and wait, right? This is also, these are the possible outcomes, okay? And you can choose to do a scar excision upfront, right? All these are possible avenues and outcomes. So neoadjuvant chemotherapy is not anymore a simple task, okay? Because you need to be sort of fluent in all these, managing all these outcomes and pathways. Just skip this part because I made this. These are basically data from local cohorts on neoadjuvant chemoradiotherapy response. Right, so a little bit about the side effects of giving neoadjuvant chemoradiotherapy. One thing is about the lymph nodes, right? Now, how many lymph nodes do you need to harvest for you to correctly stage a rectal cancer, colorectal cancer? It's not 12 anymore, right? So this is a study done by us in 2013. We suggested after doing a survival analysis that it has to be more than 40, right? To have a significant survival benefit. The number 12 has not come from survival analysis. Probably the British said we take a dozen of lymph nodes. They like these numbers, like a dozen eggs, dozen milk cartons, like Dusima. So the 12 came up, and then they looked at the 12 and found out, 12, yeah, good, there is a benefit. But they didn't actually look at it from the other hand. What if you do 6 versus 5 or 5 versus 4? Huh? So we did it like that and found out that it should be more than 14. But in 10 years, nobody actually considered it because probably we are from Sri Lanka. And then 2023, the Royal College of Pathologists now say you need to have at least 15 lymph nodes for you to correctly stage a colorectal cancer, right? So it's now 15, not 12, okay? So why I'm saying that is because once you give, the important part we missed, once you give neoadjuvant chemoradiotherapy, your lymph node harvest drops significantly, right? In this study itself, we showed that those who receive neoadjuvant chemoradiotherapy, there is a statistically significant drop in the number of lymph nodes. So when you send patients for all these advanced chemoradiotherapy regimes, they might come with their specimens after surgery will come with low number of lymph nodes, where you might not be able to meet the criteria of 15. Right? Then what do you do? At MDT, you should know, right? And you should know that it's an expected outcome. Otherwise, the oncologist will tell you, "Yo, you can't even get 15 lymph nodes for us, no man." Right? So you need to find an excuse for that. Because we have given him neoadjuvant chemoradiotherapy. There's evidence to say that there is a significant reduction, right? Not just this study, but there are so many studies which suggest that your lymph node harvest drops when you give neoadjuvant chemoradiotherapy. If the patient is young, I always go for adjuvant therapy if the number of lymph nodes are not adequate. Because by harvesting 8 nodes, you can't say somebody is in node, right? The 7 nodes that you have not looked at might have deposits. So unless you have 15, I consider them as understaged or not staged properly. So if the patient can tolerate, always send them for adjuvant chemotherapy, right? So these are decisions that you might need to discuss in your MDT. Anastomotic leak rates, are they equal in chemotherapy versus no chemotherapy? They are not. There is ample evidence to say that anastomotic leak rates are higher when you receive neoadjuvant chemoradiotherapy. This is a 2018 a large study which they have studied. Only the obesity and the neoadjuvant chemoradiotherapy were the 2 significant predictors of leak rates, right? So this is a meta-analysis which was done recently that also suggests that neoadjuvant chemoradiotherapy is the key determinant of a leak. There are other factors, but this comes up in all studies that have been published, most of the studies in meta-analysis as well, right? Then on the functional outcome, which is more important to the patient, is there a negative impact on anorectal function? Yes, when you give neoadjuvant chemoradiotherapy, right? Radiotherapy has these effects. Is there an increased incidence of urinary incontinence and sexual dysfunction? Yes, right? So all these are there. That is why you need to risk stratify your patient and send the correct patient for chemoradiotherapy rather than sending all patients, right? So you need to know these and manage the. Otherwise, all this will go in your account, right? Why the patient is performing poorly? Because your surgery was not very good. You have whacked the nerves, right? You have done something with the sphincters. That is why the patient is incontinent, right? So when you're deciding whether you're going to give a patient an ultra-low anterior resection or a APR, these things also should come into play. 75-year-old female who has given birth to 3 children vaginally, coming after neoadjuvant chemoradiotherapy, are you going to do an ultra-low anterior resection for a colorectal cancer versus an APR, right? You must tell all this to the patient. Of course, I can save your sphincters. I'm a good surgeon, but then you're not going to have a good life, right? Because evidence suggests so. You're going to leak stools. You will be much better having a stoma. Patients will understand that once you say that, right? Otherwise, you just do it and then let them experience it. That's not the way, right? So in summary, if you're talking about neoadjuvant chemoradiotherapy in this day and age, you should know about risk stratification, anatomical location, the MRI staging, prognostic features like EMVI, and do you have an organ preservation plan? That will decide what type of total neoadjuvant treatment or chemoradiotherapy that you're going to give. Then what regime? Again, this depends on the patient, availability of the resources, the tumor stage, and the organ preservation intent. So organ preservation intent now comes in over and over again, right? Whether you're going to give total neoadjuvant therapy or not, decided upon organ preservation. Restaging, another important concept now. You need to know the components. Don't say biopsy, right? Biopsy is not a part of that. You don't biopsy it. You're going to damage the scar tissue and the MRI findings hereafter. So only MRI, endoscopy, and digital rectal exam. Discussion of organ preservation at the MDT based on the outcomes, right? Anticipation and management of complications of neoadjuvant chemoradiotherapy is also part of deciding this, these regimes. Right. So that's basically it. I know that it's a lot of information for you to grasp, right? But this is how you should talk about things like neoadjuvant chemoradiotherapy. Without evidence, you can't just go out and say, out of eminence, because I'm a surgeon, I'm telling you that you need to have chemotherapy first, not radiotherapy, or something like that, right? You need to know the evidence. If you can't quote the evidence, what you're saying has no credibility, right? You can't just out of eminence go and say, this is the best regime or something like that. Why do you want to excise the scar? Because there is evidence to say when you excise the scar, patients do better. Their distant metastasis is low, right? Because of this study, right? The answer should always be connected back to evidence, right? Not what your consultant said, your supervisor said, or what your SETS class said, or anything like that. All right. So know your evidence, especially in areas like this, because these keep on changing. When we trained as surgeons, when we were students, we have not even heard of something called organ preservation for rectal cancer. Even when we were registrars, if somebody said you don't operate for rectal cancer, you would have laughed at them. Right? See how it has just come a complete circle of not operating for rectal cancer. Okay. These changes just took about 5 years, I think, to come into regular practice, right? Even by 2020, it was not in guidelines, organ preservation. But now it's in NCCN guidelines. You can preserve the organ. People used to laugh at them. They have been suggesting this from 2010, this group in Brazil, but nobody took notice of them. It took them 15 years to bring it into practice. And they started studying this back in 2000, I guess. For about 10 years, they were studying these patients who defaulted them and then came back with no tumors, right? So the evidence is very interesting. And also it makes you look more scientific, right? So learn always when you're giving an answer, connect it back to evidence, not just in colorectal surgery, everything else. Your vascular surgery, whether you're doing MRI or a CT, that's based on evidence. Whether you're giving alteplase or whether you're going to do balloon angioplasty or clot removal or whatever, is again based on evidence, right? Bypass or not, evidence. Not because you think scientifically it's the right thing to do. Okay? All right. Any questions we would like to answer? If you have any questions about today's case or in general about neoadjuvant chemoradiotherapy, total neoadjuvant therapy?
So for a patient with T3C tumor, and for the similar case we have discussed before, can we confirm that it's a complete pathological response by doing a transcranial excision, sir?
No. So when there is complete clinical response, you don't do a scar excision. You can, if the answer, you're asking me whether you can, yes, you can. But that's not the time you do the scar excision. You do the scar excision when there is a near complete response, when you have a doubt, right? When you have complete clinical response, you leave it. Right? When you have a doubt, as the case that we presented, the one that I showed, there is a small polyp, it doesn't look cancerous, but it's not a complete response because the mucosa is not smooth. Then what do? Are you going to offer the patient? If you have a doubt, the best thing to do is do an anterior resection if the patient is fit enough.
Yes, sir.
Right? But always these problems come in these kind of complex environments. This patient also doesn't want AR. My patient also didn't want AR. And doing AR, I also felt is not going to do the best for her. So that's where you do a scar excision and make sure whether it's complete pathological response or not. It's not a routine thing to excise the scar, right?
And the second thing is during the restaging, we do MRI pelvis with rectal protocol. What's the place for CECT chest abdomen pelvis? In the presence of previous metastasis or in the absence of previous metastasis, are we routinely doing in the restaging CT or not?
No, restaging CT is not indicated unless there is a evidence to say that you have a liver met or something. For pelvic staging, CT has no place nowadays other than lateral pelvic lymph nodes.
No, I'm asking about the chest abdomen, chest and abdomen, sir.
No, it's not a part of the routine reassessment. Restaging is done to see the local response for neoadjuvant treatment, right? But
And the place of CECT, chest and abdomen, comes in the follow-up.
yeah,
Not in the assessment of patients who are following TNT and organ preservation. But in any colorectal cancer, the routine regular follow-up, yes, at various intervals we are doing that, but not in this protocol.
and sometimes your oncologist might ask for CEA even during that 10-week period where after neoadjuvant chemoradiotherapy. If the CEA is rising, again, it's an indication. Because some patients with poor response to chemotherapy get liver mets while they are on chemotherapy, right? Especially if you are doing TNT, it takes a long time, right? 18 plus 5 weeks, it's about 23, about 30 weeks, right? So about 8-9 months. So during that period, you can get liver mets, right? So if there is a rise in CEA, there is a place, but not as a routine reassessment. Routine reassessment is for local reassessment, MRI, endoscopy, and DR.
Can you use the mic, please?
So in case of we have planned for an AR or APR after the neoadjuvant, we usually do CT to look for any disease progression. Like in that case, if there is any mets, the management changes.
Routinely, I usually don't do.
No.
There is no indication to.
There is no indication. I agree with Pramod on that because following neoadjuvant therapy, before we, what we do is we reassess the pelvic disease, but we don't restage the patient.
You don't have to restage unless there is an indication.
But if the CEA is rising, or if or following, if a patient's symptoms does not they don't settle. Suppose you give neoadjuvant chemoradiation and then still the patient's general condition does not improve. And if the CEA, the initial CEA, what was coming down, if it starts to go up again, and even if at the initial assessment, even if there were no distal mets, you need to look for distal mets. And even without obvious distal mets, then we would go for a PET CT. If we can't find a secondary or a reactivation of the disease.
If you have liver mets upfront, M1 disease, yes.
That is
Then
the different
that
matter.
is to reassess the response of the liver tumors, right? But in all patients, you don't need to just repeat that after chemoradiotherapy.
Sir, in colorectal liver metastasis, how the sequence of management is going to change, sir, now? The patient with rectal carcinoma primary, simultaneously he is having resectable liver mets. So
there you need to decide whether you want to do surgery first for the liver or not.
Yes, sir.
If your hepatobiliary surgeon is happy to do the surgery and give the patient to you, best option would be this again, MDT. Do the surgery for the liver, send her for total neoadjuvant, because as I said, there are other cells that you can't see. So she'll be cured of those also, and then do the rectum after total neoadjuvant. If the surgeon is happy to wait to see the response, you can give total neoadjuvant, followed by reassessment of the liver, and then he can decide whether he wants to do it with your surgery, after you, or before you, all are the same, right? So there are so many options, but in those cases, total neoadjuvant is, because it's an ugly tumor, no, it's M1 they will always benefit from total neoadjuvant treatment because you get the benefit of the chemotherapy. This was practiced even before TNT. In European countries, if you have Mets, you first attack them with chemotherapy, right? Because what you want to target is the tumors that you can't see. So consolidated systemic chemotherapy followed by attacking the ones that you can see, right? So TNT would benefit all of these people who have Mets. I think anyone who with Mets nowadays, I send them for to start with chemotherapy because what's going to kill them is not the rectal cancer. The Mets is what's going to kill them, right? Local recurrence or the tumor growing it's not pleasant, but it won't kill you. Liver Mets, lung Mets, brain Mets kill you, right?
So
The patient
if you
is,
look at
rectal,
the two regimes of TNT, so induction chemotherapy, induction regime is widely adapted for tumors with Mets. So you first give chemo and then you give radiation. Whereas for rectal cancers without obvious distal Mets, then you start with chemoradiation and then you give consolidation chemo.
rectal tumor is very symptomatic to the patient with the liver mets, sir. What we are going to approach? Is there anything first we are going for the rectal surgery and
Well, this is what the thing is. Still, you can start with induction chemotherapy because it is not only the Mets that are going to respond, but the primary as well.
Primary tumor sometimes disappears when you give chemotherapy alone, right?
thank you, sir.
There's a good response with chemotherapy for rectal cancers. So, if you want to reduce the local symptoms, one thing is you can divert and send them for neoadjuvant therapy, right? Because the symptoms are there when you're passing stools now more, and then you can start the total neoadjuvant treatment.
So we give a total neoadjuvant for lower rectal T2 tumor in the view of organ preservation.
T2?
Tumors in the lower rectum in view of organ preservation.
T2N, that depends on T2N1 or not. So as I said, the tumor needs to be in the lower third of the rectum. That's one, right? Or else it has to be a locally advanced tumor. For you to go for, you're talking about a T2 tumor, just the tumor itself is not going to say low rectum T2 tumor in a 55-year-old healthy man. You can very well go straight away for surgery.
Are we using the neoadjuvant for the sphincter? Close to the sphincter.
Yeah.
Going ahead with rather than going ahead with the surgery, can we go for a total neoadjuvant and it's completely
and
we can go for the organ preservation?
So I think there is a problem with this concept, right? What we mean by organ preservation is not to preserve the sphincter following surgery. We are not going to operate on that patient. That is the concept of organ preservation. What can be?
Yeah. So why so that patient doesn't want to have surgery? Is that your question?
Is that the question?
Does it require the neoadjuvant?
Yes.
But it is close to the sphincter. But is there a place for the neoadjuvant?
No. So why the patient not happy to have ultra low anterior resection?
Rather than any surgery.
If he wants to avoid surgery, yes, you can give them, right? But it's not an indication for neoadjuvant treatment here. If the patient is healthy, you can go for a straight surgery. Local recurrence rates are going to be very low in T2 and not, right? It's not a locally advanced tumor, okay? So if the patient is hell-bent that I don't need any surgery, then yes, you can treat them. That tumor will have very good response with total neoadjuvant treatment. If it disappears, that will with very low chances of coming back, right? But it is not indicated for that. So if you, as I said, if it's a 55-year-old healthy man with a T2 low tumor, right? T2 lung, you don't have to go for a APR also, right? You can do ultra low in a pull through, coloanal pull through, right? So there are options. You're trying to preserve the sphincters a lot. But if the patient says, no, surgery, I can't take my rectum off, you don't just wait without doing nothing. He will respond very well, right? But that is not the standard path. Assuming that the patient is adamant not to have surgery, that's a special circumstance. But if not, you can nicely do a surgery on that patient without any neoadjuvant chemoradiation. Because if it's T2, it's not going into the sphincters, right? You can nicely do a ultra low and a coloanal pull through. Not exactly in ultra
No.
lows. You can go for even a 5 millimeters.
And one other thing is that this situation occurs when following you explain the outcomes and the functional outcomes of following an ultra low anterior resection. Because the thing is, you can go straight for a ultra low anterior resection in this patient, this particular patient, and then you need to, if you are offering it, then you have to talk about low anterior resection syndrome. The moment you go into that details, then the patient would start to think, okay, now are there any other options that I can preserve my function as well as his daily routine, right? And the quality of life. All these issues comes into the picture. And at that point, if the patient insists, no, that there is this option of total neoadjuvant therapy, and then this is not protocol based. That is what Pramod
This is a
is
special
trying to tell
instance
you.
where the patient says, no, I don't want surgery, right? Because surgery is available there without a problem. And if you're going to do organ preservation, they have to tell all the other things as well. 30% risk. If you do a surgery, the chances of you getting a recurrence will be less than 2%, right? T2 tumor, okay? But if you go for the organ preservation, 30% risk that the tumor might come back, right? All those you have to tell the patient. These are special circumstance where the patient says, no, I don't want surgery by any means. You will find patients like that, and then
No, it always it depends on the quality of life following surgery.
main thing is organ preservation is not for everyone, right? The same people who proposed it are now going around the world saying that, because this became a nuisance when organ preservation came. Both surgeons and doctors are very happy to. You look like a hero. That doctor didn't take my rectum out, and the patient is also. But when you start getting local regrowths in every one in 3 patients, it's not very nice, right? Salvage surgery will be okay, but as you can see, they are not doing very well. They will get distant mets more frequently. So you have to, when you're offering something very attractive like that, you have to be very careful. Choose which one you're telling this to, right? If your patient is not willing to come every 3 months for the next 2 years, don't even, right, talk about it with that patient. There's no point, right? You have to be rational. You can't just put guidelines on patients. You have to choose which patient will match the guideline, right?
Sir, if the pre-neoadjuvant MRI shows sphincter involvement, after the neoadjuvant, the tumor responded partially.
Yeah.
Now the sphincter is not involved.
Okay.
So in that case, are we going with the pre-MRI or we are going to go preserve the sphincter?
So earlier, if you are planning for a patient for APR, you go with APR, right? But there is evidence now to say with Rectal trials, you can change, right? But after explaining to the patient, as I said, this is just like organ preservation, there is about a 25% chance that you might get a recurrence and you might have to go for a APR, right? Because if the same patient completely responded, you will not do surgery and wait, right? Same risks are there. Talk and then do it. There is a chance. There will be a proportion of patients who will do very well without recurrence, but very high recurrence rates as well, right? There was a series of French trials called Rectal, which studied this. routinely doing and changing the decision after re-evaluation. Now it is practiced, changing the decision after re-evaluation, right? That is why re-evaluation is again becoming more important, right? You can change, but given that the patient understands the risk, right? And those salvage surgeries, say if you get a recurrence in the sphincter, it's not going to be very nice. Their complications are very high, right? Perineal sinuses, perineal recurrences, skin infiltration, and so many other complications. So you have to talk all of that with the patient and then come to a conclusion. But the option is there to change your decision.
Any other questions? Any other questions for anyone online? Yeah.
We'll call it a day, no?
Yeah.
Yeah. All right. Thank you very much.
Okay.
To focus on one topic, neoadjuvant today, because there's so much to discuss, right? It'll be too much for you to grasp if we were going to dilute it with other, yes, it's almost 12 o'clock, right? So it would have been too much if we talked about fistula and hemorrhoids and all of that, right? Because this itself has so much new knowledge that has come over the past 5 to 6 years, right? This will not be completed unless you go home and try to refresh your mind on this, right? Try to refresh your knowledge, read and see whether you know the reasoning behind all of this. Do I know? If somebody asks me why, do I know what to say, right? See, few of those studies you will have to remember as a surgeon, even practicing surgeon, or at least for the sake of passing your exam, you will have to remember. Don't come to the exam and give me right answers. Right now, exam structures are also changing. So remember, most of us will be there at the exams. Don't come and give right answers without reasoning and expect to get marks. Postgraduate is not about giving the right answer, right? Even a medical student can study and give the right answer, right? It's about understanding or being able to explain how you got into the right answer, right? So please have your reasoning out or have your evidence ready when you give an answer.
And there is a question regarding rectosigmoid junction cancer. How to decide whether we manage it as rectal cancer or a colon cancer?
I can tell you there was a recent Delphi consensus that they tried to do on rectosigmoids, right? The Asian people said rectosigmoid should be recognized as a separate region and managed as colon cancers. Most of the Western, the Europeans and the Americans said, no, it should be managed like rectal cancers, right? So as far as I can tell you, there is no consensus on that. For all practical purposes, as we said, upper rectal cancers also can be managed as sigmoid cancers. No? So there is no reason why rectosigmoid cancers cannot be managed as sigmoid cancers, like in the same way, without giving any neoadjuvant radiation and so on.
It's like colon cancer, in
Yeah,
other words.
just like colon cancer. But as I said, there is no consensus on that. If you Google, you can come across that there was a very recent study, right? There was a huge discrepancy between the Asians and the Western Hemisphere on the management of rectosigmoid. They don't agree on the rectosigmoid. Okay. For all practical purposes, we still manage it as colon cancer, right? Without chemoradiotherapy.
Okay. We'll call it a day then. Yeah. Thank you.